Welcome to the short topic on hypernatremia. It's not going to be as exhaustive as what we discussed on hyponatremia, but still this one topic is carrying a decent clinical relevance. That's why we have to know certain facts on hypernatremia as well. So by definition, hypernatremia is defined as a serum sodium value of more than 144 milliequivalents per liter. So this is what we define as hypernatremia. At the same time, there are two pathophysiological aspects of development of hypernatremia. According to our equation which we have been using from the beginning, total body sodium by total body water determines the serum sodium. So hypernatremia can develop either due to excessive total body sodium, that is salt loading, or maybe due to loss of total body water. But to be honest, this loss of total body water is going to be the most common cause for development of hypernatremia. So this loss of total body water could be due to loss of water from the system, or it could be due to impaired accessibility to water. So usually hypernatremia will result as a combination of both. It's not only due to loss of free water from the body, it's also a combination of impaired accessibility to the water. Remember, a patient who can access water, even if they have loss of water from the system, they can replace that water loss by drinking a lot of water if they have access to it. If they don't have access to it, then only they will develop hypernatremia. So it's usually a combination of both. Please understand. So this loss of water can be happening in many forms. It can be from the GI tract, or it can be from the skin, or it can be from the urinary tract, or even very, very rarely, it can happen into the cells. The water loss can happen into the cells as well. And usually this water loss that's happening into the cells tend to be very transient. Only for 5 to 10 minutes they will have hypernatremia. At the same time, this impaired accessibility to water may be due to a patient who is suffering from altered mental status, or an infant who is dependent on the mother, cannot take water by themselves, or patients are having loss of thirst. So patients, what are the causes, the gastrointestinal causes that have loss of water? So the most important gastrointestinal cause that has loss of water causing hypernatremia is continuous NG tube suctioning. Very, very important cause. And after that, vomiting, diarrhea, not so important cause, but still can cause hypernatremia if the patient has impaired access to water. Again, that is the most important criteria. Then, skin losses can happen through sweating, because sweating contains a lot of sodium chloride. Continuous skin losses of sweating without any accessibility to drink water make the patient prone for hypernatremia. Similarly, urinary losses means it's always only one disease, that is diabetes insipidus. Very, very important point. And similarly, what diarrhea will produce your hypernatremia? Osmotic or secretory diarrhea? It's always the osmotic diarrhea that is going to produce hypernatremia and not the secretory diarrhea. Please be very careful. And this thing I've explained in the sodium and water balance section itself. You can go back and watch that video. Similarly, loss of thirst can happen in variety of conditions. There is an entity called primary hypodipsia or primary adipsia, where the patient will not have that urge to drink water. The thirst will be lost. Second, the patient also may have an entity called adipsic diabetes insipidus, where the patient will be having diabetes insipidus, along with it, the patient might have impaired thirst as well. So this is what we refer to as adipsic diabetes insipidus. Similarly, I told you there are some conditions where water loss can happen into the cells. Best example is when you are throwing a seizure violently, or when you are doing a strenuous exercise. So during these conditions, water can move into the cell, obviously, which comes back again to the ECF. And during this time, because of the water movement into the cells, you can result in a transient hypernatremia for 5 to 10 minutes. But please do remember that true salt overloading is extremely rare. So causing this And this could be the reason for hypernatremia, being this is very, very rare. So usually that might be iatrogenic, that is due to usage of 3% NaCl solutions or soda bicarbonate solutions, continuous infusions of soda bicarbonate or continuous infusions of hypertonic saline. So this could be the reason for this salt overload. But please do remember, this hypertonic saline infusions are given in controlled situations like raised ICP, but if the neurologist or the intensivist doesn't have any other option but continuously giving 3% NaCl to reduce the ICP, then he has to give the 3% NaCl for a long time, which might make the patient prone to develop hypernatremia. Clear? At the same time, this 3% NaCl can be used as an irrigation solution to treat patients with hydrated cyst as well, because 3% hypertonic saline injection is one of the treatment for hydrated cyst. So many conditions you can use 3% NaCl. Even for abortion they use sometimes 3% NaCl irrigation. So this could be the reason. Or second reason could be accidental. Accidentally, usually it happens when the patient has a seawater drowning or they drink a lot of seawater. Rare, but still possible. And third, it can happen as a part of child abuse. Sometimes, it has been in Western countries, cases have been described salt overloading due to child abuse, but in our countries, I don't know how much it is relevant anyway. So overall, if you take this salt excess causing hypernatremia, is generally very, very rare. You don't get it. So what are going to be the clinical features of hypernatremia? Clinical feature wise, you can classify hypernatremia into acute and chronic hypernatremia. Acute hypernatremia is one thing that develops within 24 to 48 hours. Chronic hypernatremia is the one that develops over a period of more than 48 hours. We know that the same definition applies what we use for hyponatremia as well. Chronic hypernatremia, usually the cell would have adapted nicely. Adaptation is at full swing. So that is the reason you don't get that much symptoms. In general, hypernatremia means itself neurological symptoms only. That's what you're going to get. Sodium means brain. That's all. So more than 48 hours. Chronic, usually they tend to have only altered mental status. We cannot find out anything much. There might be a little bit of poor reflexes, but this is the usual scenario. You will encounter only an altered mental status. But the challenge in chronic hypernatremia, because chronic hypernatremia happens due to some chronic comorbid sickness. So whether this altered mental status is due to hypernatremia or altered mental status is due to underlying comorbid illness, we have no idea. So that's why it's like an egg and chicken story. It's very difficult to find out. So you have to correct both hypernatremia as well as the underlying sickness like sepsis to find out whether the true cause of hypernatremia is, true cause of altered mental status is either hypernatremia or underlying cause, but still very difficult to find. Whereas in an acute hypernatremic state, like they are going to have serious neurological issues. Like they can initially start with irritability and lethargy, and they can progress to severe weakness including quadriparesis, coma, and even seizures and death. And one important danger of an acute hypernatremia is development of intracerebral hemorrhage, the mechanisms of which again we discussed in the basics of sodium and water balance. But very rarely there are case reports which have been described that has produced osmotic demyelination syndrome in patients with acute hypernatremia. But even though this is a rare entity compared to that of ODS that is developing as a result of overcorrection of hyponatremia, that is the common scenario. This is generally very, very rare. Okay, but usually in acute hypernatremia, the sodium will be in the range of 145 to 150, whereas in a chronic hypernatremia, sodium levels will be usually more than 150 to 155 range. And typical clinical feature will be described by clinical textbooks, especially pediatric textbooks, is Duffy skin. This Duffy skin is given as an important clinical feature in many pediatric textbooks, but its relevance in the current clinical practice is highly questionable. I don't know how much it's important, but still I'm telling this because it was an exam question, that's why. Now let us see how to investigate a case of hypernatremia, which is at least not important for exams. But whenever you encounter a case of hypernatremia, the next step to see is the urine osmolality. See whether the urine osmolality is less than 300 or more than 600. In the presence of hypernatremia, if the urine osmolality is less than 300, means itself tells it's a water diuresis, which means you are dealing with a diabetes insipidus, which means you are dealing with a urinary water loss. That's what I'm going to call it as a water diuresis. So if it's more than 600, it's a non-urinary water loss or due to a solute overload. So in this condition, see urinary sodium. If it's less than 25, it's non-urinary water loss, which means it could be a GI or a skin-related cause. If it's more than 100, it's likely to be a salt overload in the body. It could be either due to hydrogenic salt overload or it could be due to accidental seawater ingestion. So it's a salt overload. Suppose if it's in the range of 300 to 600, it's difficult to interpret, but you have to need a lot of other testing like desmopressin response, or you can test for urine osmolar output. So you have a lot of testing is available, which you can go back to the polyuria section and you can look for it. Now let us see the management. Management wise, you have to know what is the volume status. First, before even starting to correct the hypernatremia, see the volume status. Where the patient is hypovolemic or patient is euvolemic or hypervolemic. Remember, if the patient is hypovolemic, see whether the patient is in shock or not in shock. If the patient is hypoperfused in shock, obviously the first fluid will be normal saline only, that is isotonic 0.9% NaCl, and this is the resuscitation fluid of choice. If the patient is not in shock, just hypovolemic, probably you can try a half NS, but even though here, till you correct hypovolemia, you can use a full 0.9% normal saline itself. But once your shock is corrected, you can shift back to half normal saline. Fine. So in a case of euvolemic or hypervolemic hypernatremia, you're going to give dextrose 5 water or dextrose 2.5 water, which means 5% dextrose or 2.5% dextrose, but make sure to add insulin along with it. Because dextrose is, since even though dextrose is an excellent solution to provide free water, but this excessive glucose itself can induce glycosuria. Because of that itself, you might result in solute diuresis and it can worsen the hypernatremia. So be sure in giving insulin to these solutions. This is how you treat a euvolemic or hypervolemic hypernatremia. Then now you know what fluids to choose. You have chosen the fluids. After choosing the fluids, you have to know how to correct them and what is the rate of correction and all these things. For this, let us classify into an acute and a chronic hypernatremia. In acute hypernatremia, the rate of correction is something very easy to understand, which means the entire correction can be done within 24 hours span. Whereas in a chronic hypernatremia, usual rate of correction will be reducing the sodium by 10 milliequivalents per liter per day in 24 hours. Up to 12 you can do, but 10 is the standard number in case of a chronic hypernatremia. So how will you correct this entire serum sodium within 24 hours? So usually what we'll do is, initially we will give 3 ml per kilogram per hour of free water. So this is done till your sodium reaches 145. Then later on, we will give 1 ml per kilogram per hour of free water into the system. This is done till your sodium reaches 140. After that, you can stop or you can continue maintenance therapy if the patient is still not able to access water. So now we are using the term free water in two scenarios. So which solution has how much free water? For example, 1 liter of half normal saline will contain 500 ml of free water. But please understand, isotonic normal saline at 0.9% will not have free water at all because it is in isotonic relationship with the plasma, so it cannot produce any free water. Similarly, dextrose 5 water, dextrose 2.5 water, all these things have in 1 liter full 1000 ml as free water. which means the dextrose will be metabolized and remaining will be released into the plasma as free water only. But be again very careful, these dextrose solutions are dangerous if you don't give without insulin. And there are other formulas that can also predict this free water deficit. So especially for acute hypernatremias. So how can you calculate free water deficit? So one important formula that you might be asked in exams to calculate the free water deficit is that the total body water multiplied by serum sodium divided by 140, which is the normal sodium, minus 1. So let us take a simple analogy, a 50 kilogram old man whose age is 65 years against an elderly man who's having a serum sodium of 150 and it's an acute hypernatremia. Calculate the free water deficit. So now we know total body water in this man will be 0.5 multiplied by 50 because he's elderly man, so 0.5, 50% of the body weight. Multiplied by serum sodium is 150 divided by 140 minus 1. Clear? So here will be 25, that will be multiplied by probably 1.07, so which will come to approximately 1.7 liters. So that's what the answer will be. So which means I'm going to get around 1700 ml. So that's the derivation. So which means this patient is having 1.7 liters of free water deficit. And remember, in acute hypernatremias, all this can be corrected within 24 hours, which means I can set just 1.7 liters over next 24 hours and go on, that's all. But careful, there is one problem, because this formula of free water deficit does not care about or does not calculate the ongoing free water losses. Ongoing free water losses are there, which this formula is not going to take care at all. So how can you calculate this ongoing free water losses? So we have something called a electrolyte free water clearance. Electrolyte free water clearance that will predict the ongoing free water losses. So electrolyte free water clearance means it's given by the formula volume of the urine multiplied by 1 minus your urinary cations divided by serum sodium. So we have used this formula multiple times. Again, you can write E on top of it because it's an electrolyte free water clearance. Suppose if this electrolyte free water clearance is coming in the positive range, which means the patient is losing, there is active and ongoing free water loss in the urine. That is happening, which means whatever value, this positive value you are getting, you should add this to the existing free water deficit, and that will be the net free water deficit in the patient, and that should be the rate of correction. Careful. And similarly, if the value comes as negative, negative means there is active free water conservation that is happening in the kidney and the urine, which means the kidneys itself are trying to help you by causing some free water conservation. Not completely, but something is helping there. So this value should be subtracted from the free water deficit you have calculated and you to make the net free water correction rate. So these are the two things that you have to know. But previously you would have studied something called a simple free water clearance, for which the formula is volume of the urine multiplied by 1 minus urine osmolality by serum osmolality. So this is the formula that you have been given for free water clearance in general, but this formula is not useful for hypernatremia. So but the applications is, if the free water clearance is positive, it indicates ADH is absent or ADH is present but ineffective. We have discussed this basics already, just I am telling a recap. If the free water clearance is negative, it tells you ADH is present, at the same time it is effective as well. So it means this free water clearance is for determining the ADH action. We know that already. We have seen in the basics itself. And similarly, one problem in this chronic hypernatremia is rapid correction or overcorrection beyond 12 milliequivalents per liter per day may result in cerebral edema. because the rapid shift in the tonicity and the osmolality of the ECF. And again, chronic means they will go for adaptation. Adaptation means in hypernatremia, the brain has adapted by losing osmoles into the surroundings. Here, they will gain some extra osmoles from the surroundings and they will generate own osmoles, and so that they can adapt to the hyperosmolar state. So anyway, so if you exceed that calculation rate, correction rate, especially after 12, there is a high risk of developing cerebral edema, which is proven by multiple trials. So how will you know that you can correct? I mean, you have to correct, and what is the formula? Is there anything that can predict that you can correct it? 10 milliequivalents per liter per day. For that, you have a formula. So this formula we know already. So the magnitude of change in the serum sodium can be given by the formula infusate sodium plus potassium minus serum sodium divided by total body water plus 1. We know that, isn't it? So let us take the same example. Same old man. Let us assume he is having a chronic hypernatremia. So in this condition, let us assume I am using a dextrose 5 water as a preferred solution. Just for understanding, I am telling. Hypothetically, I am using dextrose 5 water. So what is the infused sodium and potassium? 0. Dextrose doesn't have any electrolytes at all. It's an electrolyte-free water. Minus serum sodium in this patient is 150. Divided by total body water, we already found out 25. Divided by plus 1 is 26. Here, you might be getting around minus 5.5 liters or somewhere around minus 6 liters. So this is what you will get, which, I mean, minus 5.5 milliequivalent. So this is what you will be getting. So what I am trying to tell is, if you infuse 1 liters of dextrose 5 water, my serum sodium will decrease. That's why the minus sign. Serum sodium will decrease by 5.5 milliequivalents per liter. Which means if I want to correct 10 milliequivalents per liter, I can tell 10 divided by 5.5, which will be approximately, you need some probably 1.8 to 2 liters of dextrose 5 water to correct this 10 milliequivalents per liter per day. And at the same time, you have to calculate the ongoing free water losses also, and you have to adjust accordingly. So this is the idea. At the same time, this correction rate, I told you it's 10 milliequivalents per liter per day. Suppose if you are correcting at a much lower rate is also a problem. If you are correcting at less than 6 milliequivalents per liter per day, that is going to carry a poor prognosis. That's a very standard thing that you have to know. You should not even correct at a much lower rate also. It should be at least 10 milliequivalents per liter per day, especially in the hypernatremia. So this is how the formulas may be useful for you to understand. So with this, we can close down the hypernatremia section also. And in fact, the entire sodium is getting over and entire pituitary is also over with this. We can move on to the thyroid from the next section.